Hello, everyone, and welcome. I'm Noah Reed, Vice President of Sales and Marketing for Precision Analytical, creators of the Dutch test. Thank you all for joining us today during Endometriosis Awareness Month. Today, we have Dr. Jaclyn Smeaton with us exploring the symptoms and physiology of endometriosis and how estrogen, progesterone, and cortisol play a role in its development. Dr. Smeaton is an expert in reproductive health and fertility, so this will definitely be an insightful presentation. If you're not already familiar with Precision Analytical and the Dutch test, Dutch stands for Dried Urine Test for Comprehensive Hormones. It is a group of validated tests that provide the most complete evaluation of sex and adrenal hormones, including metabolites. The simple and convenient at-home collection for patients and support on every comprehensive report from a team of hormone experts puts you in the driver's seat to help solving your patients' most complex hormone issues. Registering as a Dutch provider is easy. And if you sign up today, you'll receive up to 50% off the first 5 kits, plus free clinical consults, video tutorials, patient referrals, and expert hormone education. To sign up, just click the link we've posted in the chat and complete the Become a Provider form on our website. After you complete the form, one of our amazing representatives will reach out to you for a one-on-one appointment to answer your questions and walk you through the onboarding process. If you are a current provider with us, we encourage you to join the Dutch Test Provider Support and Networking Group on Facebook by clicking the same link posted in the chat. By joining this group, you'll receive exclusive access to case studies from our clinical team, plus peer-to-peer collaboration with other Dutch providers. The contents of this webinar are for educational and informational purposes only. The information is not to be interpreted as or mistaken for clinical advice. Please consult a medical professional or healthcare provider for medical advice, diagnosis, or treatment. Before we get started, please note we've posted today's slides in the handout section of the GoToWebinar control panel below, and we will send the recording of the slides tomorrow to everyone. If you have any questions along the way, please add them to the questions section of the control panel. Dr. Smeaton will answer as many of those questions as she can at the end of her presentation. And now let me introduce you to today's speaker. Dr. Jaclyn Smeaton is a naturopathic physician focused on infertility and reproductive health. Dr. Smeaton also works as the Senior Vice President of Medical Affairs for Emerson Ecologics and Wellevate. In addition to her private practice, Hello Fertility, she is a prolific teacher in the field of reproductive endocrinology and hormones and has trained thousands of clinicians on her treatment methodology. Dr. Smeaton has extensive leadership experience in integrative medicine, including as the president for the American Association of Naturopathic Physicians, as an ambassador for the Academy of Integrative Health and Medicine, and a board member for the Integrative Health Policy Consortium. We're very excited to have Dr. Smeaton with her first Dutch webinar. So without further ado, take it away, Dr. Smeaton.
Thank you so much, Noah. And I like how you say her first, because that implies that there could be more in the future, and that's great. I love working with you. That's right. So welcome to everyone who's here. I'm getting like text messages from many of you, of my colleagues who are here. So I'm so excited that you're here to listen along today to talk about a topic that is something that I see all the time and is really one of the most difficult things to treat in practice. And just personally, I remember when I first started in practice, I'd been in practice about 5 years. And one of my favorite mentors, Dr. Tori Hudson, real women's health expert who'd had decades of experience, I came to her and said, Tori, gosh, I just don't know what I'm doing wrong, but my patients with endometriosis, I'm really struggling to help them. And she said, you know what, it's not anything wrong with you. This is a really difficult, complex condition to treat. And it really is. So if you're in that place where you're finding it that it's really tough to make progress for patients with endometriosis, just know first and foremost, you're not alone. Definitely, I'm going to share with you the strategies that have worked the best for me in my practice. But I also will just start by saying, when it comes to endometriosis, when women are really suffering, whether it's with infertility or with pain, try to keep your mind open for them to consider all the options that are on the table, including things like laparoscopy for diagnosis and treatment. I think this can be combined really well, where you can have a laparoscopy to resect the endometriosis, get it back down to a lower level, and then you use lifestyle and natural approaches to manage it for life and help that patient really prevent having long-term consequences or a regression of illness state. So let's go ahead and dive in. If you are following this, Noah said my handle on Instagram is hello fertility. So I'd love it if you kind of posted and said hello and let me know that you were here watching too. So before we dive in about endometriosis, I want to talk a little bit about the endometrium, because I know when I learned about it in school, I think we glossed over it during gynecology, and I walked away graduating from medical school thinking about it kind of as a passive tissue, but it's really not. It actually is a endocrine organ. There's a lot of activity happening in the endometrium, and it's a really important tissue for us. So it does have receptors for both estrogen and progesterone that induce functional changes to prepare for implantation of an embryo and the establishment of pregnancy. So during the beginning of a cycle, during that follicular phase, there's a lot of estrogen that acts on the endometrium. It gets thickened, the lining thickens, and then during the luteal phase, that proliferative growing endometrium actually becomes a secretory organ. It's thick, full of these spongy spiral arterioles, lots of blood, lots of bloody tissue. And then the glandular epithelium secretes chemokines and growth factors and these cell adhesion molecules. And these create an environment where the blastocyst will be able to implant. And actually, it's really kind of cool. We're not going to get into it too much today because the focus is not fertility, but there are different chemokines that will actually attract a blastocyst to a special docking site within the endometrium. And then there are these like dome-like structures called pinnipodes that act like docking sites. And then between the pinnipodes, there's different proteins that get expressed that actually repel embryos away. So if you could think about like a magnet and how when you have that plus plus, you get this repulsion versus that plus minus, you get this attraction. There are kind of chemicals at play within the endometrium that do that to actually guide the embryo to the best place for implantation. I think it's like mind-blowingly amazing. Now, with endometriosis, the prevalence of this is about 10% in reproductive age women. It's associated with pain and with infertility. And believe it or not, it's the third most common indication for hysterectomy still for women in the United States. And this is huge. You know, estimates of healthcare costs from endometriosis, this is in 2002, which is the most recent data I could find, was $22 million. I mean, this is a really big problem for women. And, you know, I've had friends that have suffered with endometriosis, and it's incredibly impactful on their lives because it can be so debilitating that literally you're having to take time off from school or from work for a couple of days every cycle while you're managing the beginning of your period. Pretty awful experience. So endometriosis is characterized by the growth of hormone-responsive endometrial tissue outside of the uterine cavity. Most commonly, this is found on the peritoneal surface or the outside surface of the uterus. Also within the ovary, sometimes this is called a chocolate cyst. You might hear that terminology as well. Or in the rectovaginal septum, which is kind of the tissue between the rectum and the vagina. But more widely distributed lesions have been described, even on the diaphragm. Okay, it can go far away. And that's because what we see here is that the tissue ends up migrating into the abdominal cavity. And then from there, it could really move anywhere within that abdominal fluid. Now, the theories behind endometriosis actually date back to the 1600s, believe it or not. Symptoms were first described in Dutch and Belgian writings, and the first US description was by John Sampson. He was a physician at Johns Hopkins, and he described these presence of these lesions that arose from endometrial cells, which then escaped through fallopian tubes during menstruation. And so it's pretty amazing because this is like, you know, now almost 100 years old theory of retrograde menstruation and implantation of tissue. And this is the leading theory that still stands around endometriosis. So what we call retrograde menstruation is when endometrial cells shed and they move to peritoneal and subperitoneal surfaces. But then in addition, those express adhesion molecules that cause them to take hold. I'm going to share a study in a minute, but like just to give you that takeaway quickly, funny enough, like retrograde menstruation they've studied, and women that don't have endometriosis also experience the same degree of retrograde menstruation, but they don't have endometriosis. So the fact that that happens is not the problem. It's the environment that it happens in that is the problem. The other theory that's come up with endometriosis, which is not as scientifically supported, is called choriomic metaplasia. And with the idea here is that endometrial cells and peritoneal cells both arise from the same precursor cell embryologically called a coleomic cell. So the thought is that while these kind of stem cells move to coleomic cells and they become more and more specialized cells, that there could be missignaling that's occurring that's causing those cells to transform in the wrong way. I think this is really all about epigenetics. And like, if you think about it, we all of our cells carry the same DNA, but somehow, amazingly, through epigenetic signaling, the cells in our liver know to function as a liver cell, and the cells in our eye know to function as an eye cell, or a neuron, or a skin cell, or a ovarian cell. But we do this all with the same DNA. So it's almost like an epigenetic idea where there's kind of a missignaling and those cells develop in the wrong way. But the leading theory really is retrograde menstruation. So some studies have shown, like I said, that the rates of retrograde menstruation are similar in women with and without endometriosis. And this is based upon actually measurement of red blood cells in the abdominal cavity. So when they look at studies of women that have known diagnosis of endo and also known to be free of endometriosis, they actually find the same amount of red blood cells in the peritoneal cavity around the time of menstruation. So what this tells us is that we know retrograde menstruation exists, first of all, but we know that it's only part of the story, right? It's not really causative for endometriosis. So then that leads us to say, well, what does lead to endometriosis? So some of the risk factors that we know about are age. Typically endometriosis is only active after menarche and before menopause. It's most common in women who start to menstruate early and who experience fewer than 2 pregnancies. Part of the big reason for this, and we'll talk about this, is that endometriosis is an estrogen dominant condition. Now, when you're pregnant, you have a period of 9 months of time where actually you are progesterone predominant. If you think about progesterone, just the word pro meaning supporting, and gestation meaning pregnancy, that it's the progestation hormone. It's the pro-pregnancy hormone. So you get these periods of life for women of 9 months where they're obviously not cycling, they're not getting those higher estrogen levels climbing, and they have predominantly progesterone. We know that that actually can help women with endometriosis. In fact, there's many case studies out there where women with endometriosis actually, once they get pregnant, they don't have endometriosis postpartum ever. That pregnancy actually is curative for them. And that could be due to the higher levels of progesterone that actually helps to kind of reset the system. Other risk factors are menstrual cycles longer than 30 days. IUD users for more than 2 years do have higher prevalence of endometriosis. And there's increased rates in women who've experienced repeated vaginal and uterine infections. We'll talk a little bit more about this because we used to think of it only with like STIs, sexually transmitted illnesses, but now we actually know a lot more about the vaginal and uterine microbiomes and actually the gut microbiome, and there are connection points between those and the presence of endometriosis, which might be new news to some of you and might be old news to others. There's also familial relationships, particularly with severe stage disease. If you have a female relative, mother, maternal aunt, sister, etc., that have severe endometriosis, you do have a higher likelihood of that yourself. And oral contraceptive use actually has mixed data. So we get a lot of questions around this as integrative providers. People want to know, what are my risks if I take an oral contraceptive? In 1993, there was probably the biggest review that I've seen, which showed a non-significant risk reduction of 20% in women who'd been on OCPs. Now remember, OCPs can be progesterone only, that's often called a mini pill, or it would be a combination of estrogen and progesterone analogs. So, but it would be maybe lower than some women would produce on their own. But when you look at the case control data, there is mixed data, and there are some studies that show that oral contraceptives increase the risk of endometriosis. So the data out there is kind of mixed, but the best review that I've seen shows possibly a reduced risk. So what are the known factors when it comes to etiology for endometriosis? So We're going to talk a lot today about this first one, estrogen dependence, estrogen dominance, estrogen detoxification. Kind of part and parcel with that is environmental exposures. I'm not going to get into this in too much detail, but we know environmental exposures increase the risk of endometriosis. Many environmental pollutants have activity by stimulating estrogen receptors, so that doesn't help us with number one. But even things like heavy metal exposure and heavy metal toxicity can increase risk. There are some genetic associations. I'll share a couple with you that are readily testable on like commercially available genetic tests so that you can take a look at that. But there's many, it's polygenomic, you know, we probably don't even know all of them at this point in time. And then we're also going to talk about inflammation and microbiome. So these are kind of the root cause functional pieces that I look at when a patient comes in with endometriosis. So let's start with that estrogen dominance. So we know that concentrations of estrogen that go greater than 50 picograms per mil are needed to support the growth of endometriotic tissue, okay? With environmental exposures, we know that there's increased odds ratios for endo in women that are exposed to PCBs and dioxins. Also, in utero exposure to PCBs was shown to induce an endometriosis-like phenotype in the children of that F1 generation or that first generation. So what this means is that women who are pregnant and exposed, so let's say that you're dealing with a 25-year-old patient in front of you, what this is telling you is that her mother's behavior during pregnancy has influence over her risk today of endometriosis. And there's more and more illnesses where we see that the impact of parents and sometimes even grandparents' behaviors at key times for epigenetic imprinting have a greater impact on their disease risk than every single thing that they do in their own life, which is crazy. And one of the reasons why I'm so passionate about fertility work and preconception care, because truly it's preventive medicine. You know, sometimes you cannot make as many tremendous changes for the patient in front of you, but if you prepare them for pregnancy, you can really help to improve the health of the next generation. And that to me is really primary prevention. So let's talk a little bit about estrogen. This is one of the reasons why I love using the Dutch test personally for women with endometriosis. It can be so telling. So as a reminder, there are 3 key phases of estrogen detoxification. I'm sure you've heard this all before. You know, we all try to put this information together and package it in ways that make sense and stick for us. So you're going to hear mine today, and hopefully it adds to your understanding of where you're at right now. In order to properly detoxify, metabolize, excrete, and balance estrogen, it involves proper functioning of your ovaries, key producers, of your liver, key metabolizers, of your stomach, because we'll talk about stomach acid's importance with many of the metabolic processes that need to occur for estrogen to be detoxified properly. Gallbladder, intestines, kidneys, and more. So it's a polyorganic process, okay? We have to think about the health of the whole person, and I'll explain a little bit more about the role of each of these as we go forward. And I don't have a slide on this, but I do want to talk a little bit about estrogen, because I know, you know, in social media and like a lot of us, when we teach about estrogen, we talk about estrogen dominance and we talk about the downsides to it, right? But estrogen's a critical hormone for women, okay? We literally could not reproduce without it. So I just encourage you as a practitioner, especially if you're out there in a public platform, when you're sharing, make sure that you don't communicate estrogen as something to be afraid of. Make sure that you're balancing that information of the power of estrogen to support feminine health with, you know, why it's important to keep it in balance versus positioning estrogen as this bad guy, because it's critical. It's critical for menstrual cycles. It's critical for breast function. It's critical for uterine function, bone health. There's so many benefits to estrogen. We just live in a world where we're like way overexposed and our organ systems are challenged in a way where it makes it harder for us to keep it in good balance. Okay, so phase 1 of our detoxification, I like to call our cytochrome enzyme processes. This occurs mostly in the liver, and it's when estradiol gets converted using, primarily 4 different enzymes into its first stage of metabolites. Okay, so it gets transitioned into 2-hydroxyestradiol, 4-hydroxyestradiol, and then 16-hydroxyestradiol. Now, these are highly reactive intermediates, which need to have further transformation in order to be excreted. And all of us have preferences based upon our genetics and our lifestyle around what types of estrogens metabolites, stage 1 metabolites, we make. This is related to lifestyle, to diet, to supplementation, and to genetics. So we will all have a preference. This can be tested on a Dutch test. So you could run this test to see what your preference is. And we'll talk a little bit about the benefits and drawbacks of some of these different forms. Now, in addition, so these metabolites can be reactive, they can cause damage, they can cause cellular damage. So we want to make sure we can continue on that process of estrogen metabolism. And additionally, they can also still bind to estrogen receptors. They're more weak than estradiol, but they can still bind and they can still have activity. So once they're through phase 1, we're not done with them. They're still in the body, they still can have activity. And if they're not handled properly and kind of shuffled along, they can become problem children. It's kind of like you go to a birthday party and you give all these kids a bunch of sugar and cake, and then they're bouncing off the walls, and you need to like get them home and tuck them into their jammies before they can kind of be safely put to bed and calm back down. Okay. Now, in order for this phase 1 process to happen, it requires really good liver function. Remember, this happens in the liver with our cytochrome enzymes. We'll talk about which ones in a second. And it requires iron as well. So if you have a patient who's anemic, they might have challenges with this first step of estrogen detoxification. Also, there's a lot of medications and alcohol and foods that can impair our cytochrome enzymes are really active. They metabolize a lot of things. So if you're drinking or if you're taking, different medications that require the same enzymes, it actually can change our metabolism, or the availability of these enzymes to metabolize estrogen is probably the right way to put it. And that can affect our ability to detoxify estrogen. So definitely something that's important to think about. And then the other thing is that the metabolism and the preferred forms or that your body would have, of which the 2, 4, or 16 hydroxyestradiol, the preferred form is going to vary depending upon how much enzyme is around for each of your enzyme types, and that is changeable with lifestyle. So that's pretty cool because you can actually make changes and make shifts that will help people metabolize estrogen in a healthier way. So these 3 different types of metabolites that we make, we call 2-OH, 4-OH, and 16-OH. You can see that like the 2-OH category is 2-hydroxyestrone and 2-hydroxyestradiol. Estrone and estradiol are 2 forms of estrogen. Estrone is called E1 and estradiol is called E2 most of the time. Estradiol is our most potent form of estrogen. So these are metabolized by CYP1A1 and CYP1A2 enzymes. These are the quote unquote preferred pathway, less carcinogenic, generally preferred. This is the kind that we like to have. It has the weakest binding of all of these intermediates to the estrogen receptor. So it's kind of the most neutral of all of them. And it actually has been shown to have anti-proliferative effects on cancer cell lines that are stimulated by estrogen. So this is really great. It's not going to be binding so much to estrogen receptor or causing problems. This is kind of our safest detoxification pathway. The next one is the 4-OH. So 4-OH is made by the cytochrome P enzyme 1B1. This one is considered more carcinogenic. So this is actually like the really problematic child, right? This is the one that if it ends up turning down this pathway, if it's not properly metabolized, it can become the free radical called 3,4-quinone, which can cause direct DNA damage. So this is our most erratic, damaging, unpredictable, problematic form of this like intermediate. The next is the 16-hydroxyestrone. This is made by CYP3A4. This is the one that we look at the most when it comes to endometriosis. And there is data showing that this 16-OH, it tends to be more proliferative. So proliferation is great when it comes to things like bone health. As you probably know, in menopause, osteoporosis and osteopenia are really common because estrogen starts to decline. And the presence of this 16-hydroxyestrone declines. And this 16-hydroxyestrone, when it stimulates estrogen receptor, it helps proliferation of bone tissue, and that's awesome. But it also helps proliferation of tissue that we sometimes don't want to grow, like breast or breast cancer, fibroids, and endo. So it binds the most strongly of all of these to the estrogen receptor, even though it's still more weak than other estrogens. So you've got like 2-OH being the best. This is kind of where we want to shuttle people to. 4-OH is kind of the like wild child, and 16-OH is the one that pushes for tissue growth. Okay, so this is the one that we're most concerned with endometriosis. Now, all of these metabolites can still be highly reactive oxidative intermediates. So they all really need to be further biotransformed. Last thing I'll say about this is that the data does show that when we look in like serum, we actually see more 4 and 16-OH. And when we look at tissue, we see more 4 and 16-OH. When we look at urine samples, however, we see predominantly 16-OH in women with endometriosis. We don't see as much 4-OH come out of the urine, even though it is in other samples. So you might see data with both, but particularly when we look at dried urine samples, you're going to see that proliferative 16-OH be elevated. Okay, phase 2 detoxification. This is methylation, sulfation, and glucuronidation. It's basically taking those like wild child intermediates and packaging them up so that they can get out of the body. Okay, so what happens here is you see your 2-OH and 4-OH catechol estrogens get a methyl group added by catechol methyltransferase. So this is also called COMT. So COMT you might have heard of. We talk a lot about it along with MTHFR. It's really important gene SNP for us to be aware of, and a really important enzyme to be aware of. And the reason why is it can affect estrogen metabolism, but it's also associated with how we break down norepinephrine and epinephrine. So a lot of times it can affect adrenal function for people or cause feelings of anxiety. People who have a SNP that affects this enzyme tend to have higher levels of anxiety because they're not able to properly break down and process their adrenaline-related hormones as well. So when this is functioning well, we see production of 2 and 4-methoxyestrone and 2 and 4-methoxyestradiol. Then from here, they get conjugated with glucuronic acid and sulfate in the liver, which makes them even more water soluble. And then they go through sulfation and glucuronidation that supports their excretion through bile and into the gut. So remember that the first step of biotransformation happens inside of liver cells. So that's kind of step 1. Phase 2 is about getting it out of the liver cell. So it has to be made more water soluble, cross the cell membrane barrier of that liver cell, get into the bile, and then that's where it can be transported into the gut. So that entire process, which is multi-step, is phase 2 of estrogen detoxification. Phase 3 is getting it into the gut and out of the body. Now, estrogen metabolites leave the liver through bile and they get excreted through feces or urine, so kidneys and gut. Really, really important. And there's this enzyme called beta-glucuronidase, which is found in our own tissues. It's in breast tissue, for example, but it's also made in the gut by many different microbes of our microbiome, or we call this our estrobolome, which I love that word. When it's made in the gut, estrogens can be recirculated rather than excreted. So if there's more beta-glucuronidase around, what can happen is that it basically gets that nice tidy package unwrapped again and causes us to reabsorb that estrogen back into circulation. Okay, that increases our overall estrogen load because it has to be metabolized again in order to be excreted. So this is my summary slide. I love summary slides. If you've ever taken a class with me, I love summary slides that you can just if you could just keep one slide of what you're going to learn today, this is it. Different phases of detoxification, kind of your key steps, potential signs of a problem, which I'm going to walk you through what I look for on the Dutch test specifically, and then things that you can do to help. Some things to think about. So with that phase 1, it requires iron. You also can support more detoxification through those preferred pathways through things like DIM, indole 3-carbinol, quercetin, and sulforaphane. One thing to keep in mind with DIM is that DIM will lower the total estrogen in circulation. I'm going to share a case with you where I made a mistake, clinical mistake, learned from it, and it was DIM related. And that's because I didn't run a Dutch test to begin with. I ran serum tests and made decisions based upon that, and the patient got worse. But I'll share a little bit more with you about that. Phase 2, again, this is that neutralization and making it more water soluble. Sulforaphane is awesome to utilize for this. So sulforaphane can be taken in supplement form. It also is made from broccoli. So broccoli sprouts are a great way to get sulforaphane. You want to chew them raw. You also can do it with fresh broccoli, but it has to be raw, so you crunch it up, or alternately, you would chop it up or like smash it up and then let it sit out for about 45 minutes before you cook it. And that will also make sulforaphane, and some of that gets retained even through cooking. It also requires support of that COMT enzyme, and that requires things like SAMe, choline, trimethylglycine and betaine, methyl B12, methylfolate, methyl Bs. These are all methyl donors, methionine, another methyl donor. And then zinc and magnesium are required as well. And there are some things that will slow down this pathway. One of them is estrogen dominance, which stinks because it's like a vicious circle. But also gut infections, heavy metals, PCBs, BPA, different nutrient deficiencies, especially the ones that are above that are required. And then I also like to put on here quercetin and green tea can slow down that enzyme function. So I think it's okay to have like a little bit of green tea to consume it, but I wouldn't be putting patients on like EGCG if they struggle with their COMT pathways, because you could be making things worse. Phase 3, that kind of gut support, you want to do things that support healthy gut function, gut lining, and gut microbiome. So make sure that they're having a bowel movement every day. Make sure they're making adequate stomach acid. Some great places to start are increasing water and fiber through food, through diversity of food, so that they get a wide variety of prebiotics. That can really help to build a more stable, more diverse, and more helpful microbiome. Also prebiotics, and calcium D-glucarate is actually, it blocks the function of beta-glucuronidase. So if you take calcium D-glucarate to support estrogen, that's how it helps. It actually blocks that beta-glucuronidase function to keep the estrogen flowing out of the body. Unpeeled raw carrots are like have particularly awesome types of prebiotic fibers that are really good for the gut microbiome and beta-glucuronidase in particular. So that's a good one to tell patients as you wash the carrots, but don't peel them and then eat them up raw. So great thing to add for snacks. Okay, other known factors for etiology, genetics. So there's a 51% kind of weighting in susceptibility thought to be due to genetics. That's pretty heavy for an illness. There's a lot of genes. These are involved in things like how we process xenobiotics, our inflammatory response, and how we react to steroid hormones and process steroid hormones. So I've listed a couple of examples here. These are all ones that are, again, testable on like your standard commercially available genetic tests. So you could see the SNPs, and I put in here like which alleles are associated with either higher or lower odds of endometriosis. So you could take a look at this to see whether a patient's genetics are like really supporting endometriosis or like working in their favor. Okay, inflammation. I'm not going to spend too much time talking about immune health and inflammation, but in early endometriosis, there's elevated levels of cytokines, lymphocytes, and prostaglandins found in the peritoneal fluid. We also know that women with endometriosis have decreased T cell reactivity and NK cell cytotoxicity, which leads to an increased likelihood of implantation of endometriotic tissue. We don't have those kind of first fighters to kind of get rid of that tissue that's abnormal in that location. We've also seen studies where autoimmune antibodies have been seen in early endometriosis. So we don't know all of the details of exactly what's happening. And another challenge with the research around inflammation and endo is that we don't know if the inflammatory changes cause endometriosis or whether they're the result of endometriosis being present. So we kind of, it's like what comes first, the chicken and the egg. We don't know if the inflammation is the problem or the endometriosis is the problem, but I would say that you do want to make sure the immune system is well balanced to really support women well, and make sure inflammation is not a contributory factor for them. Okay, microbiome. So we've talked about the role of the microbiome when it comes to beta-glucuronidase and resorption of estrogen from the gut to really allow for safe removal through stool and urine. Also, inflammation is linked to GI health and microbiome. So these causations and etiologies end up crossing over and interacting. But there are some really interesting studies around particular microbiome agents or, friends in our gut. The endometriosis does appear to be associated with increased presence of proteobacteria, enterobacteriaceae, streptococcus, and E. coli across various microbiome sites. And then the phylum Firmicutes and the genus Gardnerella also appear to have an association when they're present vaginally. So these are things where you want a balanced microbiome. If you have high beta-glucuronidase, which you can test for, you also can consider adding calcium D-glucarate while you fix the gut to help to block its activity until you can get the microbiome in better shape. So if there's microbiome or GI related issues, things that I look for in my patients are constipation, bloating, gas, irregularity, difficulty digesting foods, pain, things like that, that would make me think that we need to address this as a factor. You want to work to improve the microbiome. Diverse diet is first and foremost the best thing you can do. Help your patient get at least 1 bowel movement per day. Make sure they're drinking, getting enough fiber. And then again, you could consider calcium D-glucarate. Avoiding things that are problems like antibiotics and junk food and alcohol as much as possible. And then I had to put movement on here because a lot of patients, this is like one of the problems with our sedentary lifestyle, is their gut motility like radically declines. And we need the mobilization and movement of our legs actually like jostling our gut to keep things moving. Movement is very good for digestion. So if your patient struggles with constipation or digestive illness, walking every day is awesome, especially if you can get outside in nature, because they get the benefit of the movement, but then they also get this calming vagal nerve stimulation from a relaxing walk, being outside in nature. That can be a really great gut reset as well. So something to consider for any patient with GI dysfunction is making sure they have movement as an important part of their day, preferably walking. Now, when I was kind of prepping this presentation, I came across this really cool study that I really wanted to share. It's only a rat study, never seen something like this on humans, but it's so fascinating. So this was in 2018, and they did a study where 21 days after birth, they started to expose rats to one of 2 environments, either no enrichment or what they called an enriched environment. So no enrichments was like 2 rats per cage in a standard cage. The enriched environment was more space, so a larger cage. There actually were 4 rats in a much larger space. So they had more socialization, kind of cool, more toys and more nesting materials. Then otherwise everything was the same, okay? Then at 8 weeks later, they surgically implanted the rats with endometriosis. And then 60 days later, they were reassessed. The group in the enriched environment had a 28% reduction over the control group in the number of endometriosis vesicles present, and all of those vesicles were significantly smaller. So this would mean like fewer incidents of disease and earlier stage disease if it were, associated with humans. They also noticed that the rats with enriched environment had lower baseline anxiety levels, lower corticotropin releasing hormone, and lower glucocorticoid receptors in the vesicles. So kind of 2 things out of this. We know endometrial tissue actually has glucocorticoid receptors, which means it has responses to glucocorticoids or our stress hormones. The second is that our environment and our stress level can actually change that endometrial tissue, okay? So stress reduction in rats at least is a causative or aggravating, exacerbating factor for endometriosis. And so this is pretty cool because this is something else that from a lifestyle perspective, we really can help people control and we can really understand. So this is where that stress piece does come into play. There is a connection between adrenal function and endometriosis. I always recommend when I talk about adrenal function that you guys read the book, Why Zebras Don't Get Ulcers by, I think his name is Zapolsky, if they say his name wrong. You can't miss the title though. There's only going to be one like that. It's such a great book. And if you want to better understand the relationship that stress and stress hormones play on different systems of the body, this is a great one to have. I own a copy in print and on Audible, and I literally listen to it or read it like at least once a year. Sometimes I only reread certain chapters about certain bodily systems. So it's a really easy read, but really, really well done. It's pretty old, but still a really great read if you want to better understand the science behind stress and the impact on the body. Okay, so I do want to share with you kind of down and dirty how I use the Dutch test with patients with endometriosis and why I find it so helpful. So the first is that it tells you a lot about estrogen and about its metabolites. Now, when I do this, I normally run the Dutch Plus, and on page 3 of the Dutch Plus, you can see here, hopefully you're able to see my cursor. You can see the total estrogen, E1, E2, and E3 right here, okay? So you can see this patient is within the healthy range. I thought I'd start with a good example, a good healthy example, which this was mine. And you can see that you read the dials from star to star. This is kind of the normal range based upon that patient's age. And you can see that they're in the green here. Then I look at the relative progesterone level as well. So you can see, like, are they really estrogen dominant or are they progesterone dominant? That hardly ever happens. But here you can see they're in pretty good balance. Sorry about that. Then I look at the phase 1 detoxification, and we talked about this. Phase 1 is represented right here on the Dutch test. So you can see that's showing estrone moving to the 2, the 4, and the 16 hydroxy metabolites. The 2, just as a reminder, is the preferred form. They make it easy because they show that 2 with a green arrow. The red is the like dangerous wild child 4 form that I talked about that can become a quinone and actually cause DNA damage. They make that in red. And then the one that we look at with endometriosis primarily is 16-OH. So you can see with this patient, they have pretty normal levels of estrogen and progesterone, and their metabolism is relatively balanced. They're making a decent amount of 16-OH, but also 2-OH as well. Okay, then I look at phase 2 reactivity here. And so that would be looking at this COMT. I lost my own cursor here. The COMT pathway, where the 2-OH-E1 on the good kind of shifts down to the 2-methoxy E1, and they put it into this fan dial so that you can kind of compare the relative amounts to see how active is that COMT methylation process. And that's because you can see that there is a lot of this metabolite and then relatively less of this one. This person doesn't convert it very well. Ideally, you would see these arrows point in the same direction, which would show you that they're a pretty efficient converter. So that's kind of the estrogen piece that I like to look at on the test here. So when you're looking at it, like, you can see the sex hormones, kind of the total overall here. This is a separate patient you can see here. In this patient, she had screaming high estrogen and like pretty decent progesterone, very, very low testosterone. This was a fertility patient that had endometriosis and other issues with egg quality due to low androgens, which we learned about on here as well. But you can see in this case, her estradiol is super, super high, okay? Then when we look further down at how things metabolize, then you can see that that high excess amount of estrogen is getting metabolized, preferred towards the 16-OH form, okay? She has high metabolism elsewhere as well, but then she also has low COMT methylation activity. And because her estrogen is so high, I was also suspicious, based upon her history, that she had some gut issues that made her recirculate estrogens as well. So you can get so much inference of information here to really help to guide you in your path. And with this patient, something like DIM plus supporting the other steps in the pathway can be great because it actually will lower the total level of estrogen in circulation, and that's what we would want for her. Okay, but generally, I should say this, when you're building a plan, you want to start with phase 3 or that gut first. Once that's operating efficiently, then you'd add in phase 2, and then you'd add in phase 1, because what you don't want to do is make more dangerous metabolites and not be able to move them through the entire detoxification pathway. So you kind of want to go 3, 2, 1 when it comes to a treatment plan here. This is another example of a patient that actually had raging endometriosis, and her sex hormone levels were actually kind of low, like her estrogen and progesterone were kind of low. But then when we looked at metabolites, you can see here she made like almost no 2-OH, a little bit of 4-OH, and then off the chart 16-OH. So even though she had low estrogen, she was making so much of that 16-hydroxy metabolite still that was causing her uterus to be overstimulated in that growth way. Okay, so other things, that's like the best, the information that I really want to look at the most. And I'm going to give you a case example in a minute. But other things that I love to look at that I want to make sure I point out is this page, which is later on. I want to say it's like page 7 maybe on the Dutch Plus test. And this looks at some of the other markers for inflammation and oxidative stress and some of the underlying drivers. Okay, so for example, if methylation activity is low, you might find, I lost my presentation, there we go. You might find that vitamin B12 or vitamin B6 is low, and that supplementing with those methylated versions of those B vitamins could be beneficial. Or you might find glutathione to be low, or my favorite marker on here is the bottom one, 8-OHDG, which is 8-hydroxy-deoxyguanosine. And this is actually a urine marker for oxidative stress in the body. And one of my very favorite parts of it's like a bonus cherry on top that I get with the Dutch test when I run it for patients, because you can identify take a look at. Lastly, of course, the Dutch tests for adrenal dysfunction as well. So when we look at the role that stress may play as an exacerbating factor, you get the opportunity to take a look at the cortisol pattern. I'm not going to get into that too much here because there is so much education that Precision Analytical provides on this. So I would check out their website because there's awesome pre-recorded webinars that can give you so much great information. But generally, if you're seeing really elevated glucocorticoids for patients, then that's something that you want to address. This patient actually has a little bit of that delayed awakening response. So that's something we wanted to fix for her to kind of help her have a better cortisol awakening response. However, what I'm most concerned about with endometriosis would be that you have really high levels of glucocorticoids and cortisol throughout the body. Now, you guys, I can't talk about endometriosis without talking a little bit about fertility, so I hope you'll give me the chance to go through just one slide, which infertile women are 6 to 8 times more likely to have endometriosis than fertile women. The proposed mechanisms are that it could distort pelvic anatomy, cause endocrine or ovulatory abnormality, or be the result of that. And also due to all of these different immune issues that happen in the endometrium. Okay, there's a lot of peritoneal changes that happen with inflammation associated with endometriosis. I'm going to give you guys these slides, but I don't want to spend a ton of time today talking about treatments. I really wanted you to look at how you can assess it, but I wanted to share some of the data out there and the things that I find to be most helpful. I've addressed the ones that I really love with endometriosis, but wanted to provide you some additional backups, including some conventional treatment options, kind of the goals of treatment from how I look at it from a naturopathic perspective is looking at all of these different factors, figuring out which ones are a problem for that particular patient, and then working to address those. And I'll just say with endometriosis, like I started with, it's tough to treat. The most important thing is avoidance and lifestyle, avoidance of exacerbating factor, and getting those lifestyle things into place like we talked about. I think we've talked about the majority of these already as well. But I will add that pain relief is important, okay? If people are taking NSAID medications so frequently for pain relief, there's great options, alternate options, like for herbals, for example. So some of the great ones, like the analgesics, would be like Dong Quai. Also, black cohosh. Did you know black cohosh was, when it first came out, it wasn't about hot flashes. It was actually about uterine pain. It's a uterine sedative. So I learned that from Tira Nolodog, and that's a great use of that herb, black cohosh. Lots of other options for anti-inflammatories and antispasmodics that can help ease the discomfort that women experience with endometriosis. I also think about immunomodulation, so a few of my favorite herbs are listed there. And then improving uterine circulation can be really important. So some of those, my favorite herbs are here, but another favorite thing that I like to recommend is manual therapies. And when it comes to endometriosis, adding a manual therapy like pelvic PT or Mayan abdominal massage has actually been shown to increase pregnancy rates in women with endometriosis. Now, TCM also has its own kind of stagnation and blood stasis underlying cause for endometriosis. So there are some available formulas in the US that work to address that, along with different acupuncture points. And in the TCM literature, there's a ton of information on a component of cotton root called gossypol. We don't really use this in the United States. It's super potent. So cotton root, just so you know, it actually can, it's an abortifacient, it's a drop dose herb. So I would not use it without significant herbal experience. And I've never used it for endometriosis, but I find these studies fascinating. This is actually turned into a drug in China, and I think there could be huge potential. I've just never used it personally in practice, but I feel like it's probably a component of our herbal formulary that we should find some way to explore from a research perspective. You just have to make sure women are not trying to conceive when they were using it. Okay, just want to end with a quick case. So this is a patient, she'd been trying to conceive for a year. Her cycles were regular. She had a lot of signs of endometriosis and came in with that suspected, though she'd never had an laparoscopy, heavy bleeding, clots, severe cramping. Her sister had infertility and then got diagnosed with endometriosis. And she also had imaging showing a blocked fallopian tube, which they thought could be an endometrial implant. She was one of those patients that had like a super clean lifestyle. We worked her partner up. He was great. And so we ran serum hormones first. Her estradiol was 58.9. FSH looked great. AMH looked really great. So for the most part, her estradiol was slightly elevated, but her progesterone looked really good. And so, you know, we kind of went on the presumptive diagnosis of endometriosis. And I thought, well, her estradiol is a little high. So I put her on a plan focused on egg quality, lengthening her cycles a bit, and focused on estrogen metabolism. And it included DIM. Her cycles got worse, so they got shorter on the plan. And so I had to dig deeper. So I ordered a cycle map for her, which is another Dutch test. And what I found was that, sorry for losing my slide here. What I found was that if you look at cycle day 3, when we test estradiol, you can see on this estrogens chart on the top, her levels were normal or high normal on cycle day 3, but then they were like very, very low throughout the rest of the cycle. So when I put her on DIM, it lowered it even further and she got worse. Okay. You can see that here, the serum equivalent. So if you look at day 3, which is the time point all the way to the left, that's the only time she's like in the normal range. If you look at the whole cycle, she's overall quite low. And so we ran the Dutch test. I could see here her estradiol was actually on the low end. Her cortisol was screaming high in the evening as well. And when we looked at her estrogen metabolites, she did have a metabolic preference to the 4-OH. And in this case, her 16 was quite low, but the 4 was quite high, which can also be associated with endo. And so we had to, work on COMT with her more so than phase 1 metabolism. And I would never have known that had I not run this test and been able to see that breakdown. Okay. So with her, we put her on magnesium and zinc and SAMe and trimethylglycine and all these different things to support phase 2 and 3 versus focusing on phase 1. And then she got a lot better. About 3 months later, she started to ovulate. Her ovulation pushed out a little farther. She had a longer cycle and she conceived within 2 cycles. So we would never have been able to achieve that without the addition of information from kind of the more of the functional testing like the Dutch provides. So I know I went through this as a whirlwind, but you guys will get those slides. So when it comes to treatments and things like that, you can take a look at some of my favorites. I also want to share with you that I do teach like a fertility. It's about a 10-hour course that you can kind of self-do online for CE. It's approved for CE in the US and Canada. So if you are interested in learning more about fertility, we talk about endo, but we talk about fertility a lot. You can see the website here, and there's a QR code, so you can kind of scan it with your phone. Also, like one of the best ways to reach me is on Instagram. So if you have case questions that come up or questions about the webinar, you can definitely reach out to me that way through a DM, and you can see my Instagram connection point there. And oh, where is your final slide? We're missing one in here. But I wanted to just share also that, Noah mentioned before at the start of the webinar that they offer the discount on the 5 tests at up to 50% off. And if you've not done a Dutch test before, I would highly recommend you take advantage of that deal. I wish I could get it again, because I did get that when I first signed up, and I ran it on myself, I ran it on a friend, and I ran it on a few patients. And really, I found that it can feel intimidating at first to run the test if you've never seen it before, but now it feels easy to me, and I know what I like to look for and how I interpret it, and it just takes more practice. And so it helps to lower the intimidation factor when you can like do it on yourself and do it on a few patients. And I will say, like, to the merit of the team at Precision Analytical, the docs are awesome there, and they helped me a lot, like really make sure that I got the most out of the test by walking me through those tests, and they were great to like set up a time to talk with. So just to kind of second that, and I hope that you do take advantage of that.
We do have 10 naturopathic doctors on staff ready to support you at any time. We have put the link in the chat. If you do want to sign up to become a provider, one of our account specialists will reach out to you and set up a time for you to go through to walk through the onboarding process. And they'll also offer you the 5 at half off, so they can give you more details on that. If you're interested, just fill out the form. So thank you everybody for joining. We do have quite a few questions that we're going to get to in just a second as we kind of gather those questions and put them together. Make sure you follow us on Instagram at Dutch Test. We have some really exciting news that's going to be coming out in the next couple of weeks. So you're going to want to follow along and watch for that news that is coming. And now on to the questions. We'll try to get to as many as we can. There's a lot of really, really good questions, but we've picked a select few that we can get through. So we'll start with at the top, and kind of just a question that happened a couple of times is, Dr. Smeaton, do you find that mold toxicity is ever a factor in endometriosis?
So I haven't seen data specifically connecting mold toxicity to endometriosis, but when I think about the underlying causes of endometriosis and the environment that has to be present for retrograde menstruation to trigger endometriosis, I see that mold could really fit in there as a trigger. When I think about things like the immune dysregulation that can be caused by mold exposures, as well as the inflammation that it can cause throughout the body, and microbiome disruption. So I think you actually could see how mold could touch several of the known etiological factors. So it wouldn't surprise me if there was a connection there. I think there's a lot of relevance there.
Great, thanks for answering that. Is it okay to take DIM if the methylation process is sluggish, or should we work on methylation first?
So I always recommend that you start at the end, okay, when it comes to estrogen metabolism, because it's important for estrogen to move through the entire process. So DIM has a really positive impact on phase 1 metabolism, but if phase 2 is not happening efficiently, you could actually help patients make more dangerous metabolites that they don't know what to do with. So in that case, I would start with, digestion and stage 3, and then stage 2, and making sure that COMT is happening efficiently. So what I would do is I would be working on COMT. I might run another test for that patient, another Dutch, to make sure that that fan has gone back up, so that if it was showing low activity, it's now showing high activity. After, I would say probably 4 to 8 weeks is how long I would wait to retest. Once I saw that that looked good, then I would add in phase 1 support to be able to kind of move them through that way. And you might actually find that supporting phase 2 eliminates what looks like your need for phase 1 support, because now that things are moving along, all of those dials that are turned too high start to turn down because things are flowing a little bit better. So you might find that the phase 2 is all that they need and you never even need the DIMS.
That leads me into another great question, and I want you to know there is no pressure to answer this a right or a wrong way. I'm not setting you up for anything here. If it makes perfect sense to work through the detox pathways backwards when you're starting with 3 and working to 1, and it's indicated, would you start with a stool test first or with a Dutch test for your baseline testing?
I like to know what's happening with the Dutch test. And the reason why is that I like to see if estrogen metabolites are really high. And that can sometimes tell you that there is a clog in your process, right? So I think of it like a funnel, right? You have that estrogen, or a bucket is a great way to think about it. I use this a lot for toxicity types of images when I talk with patients too, is like if you have a bucket and there's a spigot at the bottom that's only so big or allows so much out, and then you're pouring more in the top, you know, what's happening to the level in between? Is more draining, or is it going to overflow on you? And so when you run the Dutch test, I can see whether estrogen's overflowing, and that generally points me to think that there's a problem along the way. And if their detoxification pathways look okay, even if they don't, I'm often thinking about the gut, and I look at the patient's health to see whether something needs to happen with the gut. Oftentimes, I'll start with just those microbiome supportive protocols without testing, because of course, with the microbiome, we're still learning about the patterns that exist that are beneficial. But sometimes you can pick up a gut infection that's causing disruption in the microbiome. So I think they're totally different and very complementary. I like to look at the Dutch test first and then kind of go from there. But I could see that someone might make a different choice and say, I want to evaluate gut health first. And that might be a step for a patient where, you know, gut symptoms are hugely predominant for them, because you want to solve their biggest pain point first. So I think it could kind of vary on the patient.
Yeah, based on symptoms, which is fair. I appreciate that. Didn't mean to set you up for an answer there, but I appreciate your answer. If someone has confirmed endometriosis, could that also cause elevated insulin, which could be confused for PCOS? So the patient they're specifically talking about seems to have no other PCOS symptoms except for facial chin hair.
So if a patient had no symptoms of PCOS other than chin hair, but no other hormonal patterns for it, I wouldn't be thinking that endometriosis is the cause of that. So I would say probably not. I might look at other factors involved, or like genetics, like some families, you know, even women without PCOS will have random chin hairs. So I know that's a super scientific answer. Sorry that that's the best that I've got, but I wouldn't think that endometriosis is causing increased androgens, which is generally, like when we think about hirsutism, we think about increased androgens being the cause of that. Endometriosis is not really associated with increased androgens.
They could also be looking at the 5A, 5B pathways on the Dutch test as well. That might have something to do with that a little bit. So that's also helpful. I appreciate that. So one person said they've been noticing that some of their endometriosis clients have low estradiol and normal progesterone on their Dutch tests, even young clients in their 20s. What would be the cause of this, and is there anything that can be done?
Yeah, so this is where I would look at those metabolic pathways for phase 1. And I think I showed you a couple of examples with patients I've had where I've had exactly that same pattern where, and I tend to, because I'm doing fertility work, I almost always run serum labs first on a patient, because that's the population that I'm seeing, and I'm comparing it to like published serum normals for other fertility parameters. So I'll see a lot where estrogen is not elevated, but women have endometriosis. And so that's where, like when I showed you the example of how I use the Dutch cycle map, that can be really telling, because the problem with serum is that it's only a single snapshot. It doesn't tell you what's happening throughout the whole cycle. And if you have patients where you run serum labs and they just don't make sense based upon the patient's symptoms, or maybe the patient sometimes shows signs and symptoms of estrogen dominance and sometimes shows like low estrogen type symptoms, or it just feels confusing, those are the awesome patients to run a cycle map on, because you can really see what's happening throughout the whole cycle. And you might find that that time you tested estrogen and saw that it was low is unique to the pattern seen throughout the rest of the cycle. Also, if you might see it low but see the 16 metabolite high, and that can also be a risk factor, or really that proliferative metabolite could be what the problem is. It's not that the overall estrogen is too high, it's that that proliferative metabolite is too high.
That's why in the past couple of years we added the option to bundle the Dutch Plus with the cycle mapping as a really big combination, because that whole connection is really interesting. Couple supplemental questions. Have you noticed that calcium D-glucarate lowers testosterone when you give it to certain patients?
I have. It's not for everyone, but for some patients it can. So, you know, probably not beta-glucuronidase related, but it can have other, you know, influences on the body. So I don't see that consistently, but I have seen it sometimes.
Are the headaches associated with DIM a positive result of how estrogen is being broken down, or a negative result?
Well, I don't think pain is a positive outcome generally for people. So if DIM is triggering a headache, I would want to look at why that is. Some of the things that you might think about is that oftentimes sudden drops in hormone levels will trigger symptoms. So you see this like when progesterone drops postpartum and women have a couple of days where they feel like their, you know, emotions are going totally crazy. That would be an example. Or women who get PMS symptoms. That's because you're seeing this drop in progesterone, drop in estrogen. And so if DIM is lowering estrogen and women are getting a headache, what I might try first is actually separating out the dosing. So if they're taking all of it at once in the morning, for example, I might have them spread it out to twice a day or 3 times a day rather than just once, which will, rather than getting a peak and a trough throughout the 24-hour cycle, you're going to have like smaller peaks and troughs, and it's going to be a little bit more steady state. That might be the first thing I would think about for that patient.
I am setting you up for an answer here, but if I'm a provider and I'd like to purchase supplements that you've mentioned today, what is a great location for me to find all of my options when it comes to my supplement options?
That must be an Emerson employee who put that question in there.
Well, no.
Whoever it was, you know, on my team that kind of launched that softball. So of course, you know, I would recommend that you work with Emerson, Ecologics, and Wellevate. So we have about 400 professional supplement lines that we carry. So we're kind of brand agnostic. And our team can actually help direct you to the best kind of products and combinations that are suitable for your patient. So it's emersonecologics.com is the website, and we also have a virtual dispensary. So if you don't want to stock product in your office, we can also help you make it available for free. Not for free, the product's not free, the platform is free to your patients so that you don't have to stock and do inventory management and things like that.
I will say as a patient, it is the best platform that I've worked with, so it's great. What is the best way to lower testosterone when all hormone levels are high?
We weren't talking about testosterone today, and that's a very complex question. So again, that's like a picture that you have to look at, where is the testosterone coming from? I use the Dutch test a lot for that as well, because you can have kind of adrenal drivers, or you can have drivers due to increased or decreased aromatase activity. So there's a lot of different drivers for that. So I would say what I would do is run the Dutch test to figure out where that's coming from, and then address that root cause. It's not so easy that you can just give a supplement to bring it down. You know, I would say the most common supplement that's utilized would be something, well, maybe a combination. It would just depend on the factors for that woman, really, because it could be something like an inositol that's needed for more blood sugar balance to bring it down. It really is hard to just provide one answer without knowing more about the patient.
I told you I wouldn't set you up for questions like that, and then I did, so I apologize. Specifically, what did you do to support the client of yours with low and early daytime cortisol and then sky-high evening cortisol?
Oh, I love your question. So first of all, for the person who submitted the last question about the testosterone, if you want to send me more details about the case, I'm happy to like give you more targeted advice once I know a little bit more. So with the patient with the sky high evening cortisol, so they have like what we would call a flipped curve, right? They're getting really high in the evening, and that's when they should be really low. So there's a lot that we do. I always look at lifestyle, and I look at what are they doing in their life that might be triggering. So maybe evenings are particularly stressful for some reason, and how can we kind of shift that away or kind of get those triggers to be lower. I could relate because I'm a mom of toddlers, so sometimes evenings feel pretty stressful for me, and I think if you tested me on those nights, that bedtime was the same way. But then from a supplement perspective, there's a lot of different things that you can utilize to bring cortisol down. So one of my favorites is magnolia bark, which is, you can also get an extract called hinokiol, which is really effective. That's one of my favorites to utilize in the evening. And I like to combine your kind of classic adrenal calming agents, which other favorites of mine are like ashwagandha and holy basil. From a botanical perspective, making sure a patient has adequate B vitamins in place. I love L-theanine also. And then I like to combine it with what we call nervine herbs, which are more of like a tonic for the nervous system. And my favorite one for that is called Avena, which is actually oat, milky oat seed. And that's a really nice one to combine with adrenals.
And we'll end with this question. Why do you prefer the Dutch Plus versus the Dutch Complete?
Oh my gosh. So the Dutch, Noah, I need your help with this one, because when I assessed, the Dutch Plus is a little bit more comprehensive. So it has the cortisol awakening response in it, which I really wanted. It has the full kind of metabolic breakdown and metabolism of hormones, which I feel like I need all the time. And then I like that it also has that extra box I showed you with the green lines with things like 8-OHDG. Now, the difference I think with the Complete is that it does not contain the cortisol awakening response. Is that the only difference?
That is the only difference, is that we use saliva for the cortisol awakening response portion. Otherwise, and the diurnal pattern that you get throughout the day. Otherwise, that is the only difference between the two, but it does give you that morning waking cortisol awakening response.
Yeah, and I think, that's a newer addition for me with the cortisol awakening response. I mean, I didn't really learn about that until maybe 3 or 4 years ago, where I started to learn more about like the criticality of that time and how it's such an important marker for overall adrenal function, which is when I switched to adding that to the panel to really better understand the morning. And again, like that is something where I'm a reproductive hormone expert. If you want to really dive into that, like go listen to the webinars that Dutch has on their website, because there's ones that specifically talk about that I've listened to, and they can teach better than I can about that.
We call it a mini stress test because it is now scientifically proven that waking up is the most stressful event of your day. And that cortisol awakening response is a mimic of what happens during stressful events throughout the day, which is why we added in the salivary cortisol awakening response when we did. So yeah, it's a great test, but both are still going to give you great options. So thank you all again for joining us today. Make sure you follow us on Instagram @DutchTest so you can hear those big announcements that we have coming in the next few weeks. Also, make sure you check your inboxes tomorrow for a link to this recording and all the downloaded slides. If you have any additional questions about today's content or for general questions about the Dutch test, please email our customer support team at info@dutchtest.com. Thanks for coming.